In this presentation, we're going to talk about fabrication of models and casts. We're going to talk about the model materials, methods of pinning, and articulation. Model materials. In most of the cases, we start with the dental impressions, which are the negative representations of the patient's mouth. The cast or model is a positive representation of the patient's mouth. And this is very important to keep this in mind. So this is how a case starts. A patient comes to the dentist and presents a problem. It could be tooth decay, it could be a more complicated problem, more teeth involved. So he comes to the office, the doctor takes a visual look first to see what's going on, then they might take an x-ray to see the extent of the cavity, if the cavity extended deeper into the pulp or reaches the root of the tooth. And based on what the doctor sees, he or she develops a treatment plan. So a plan of action, how to limit the spread of the cavity and also to restore the oral function and aesthetic through dental restoration. And the first thing the doctor does after the treatment plan is agreed upon with the dentist and the patient is to prepare the tooth. So what that's supposed to mean? It's the doctor gets based on the x-rays, he starts drilling and cutting the portions of the tooth that are damaged and preparing the tooth to receive restoration. And once the preparation is done, the dentist take an impression and he send it to the lab so we can use that impression to fabricate the cast, to mount the case, and then to wax up, sprue, invest, and finish the final restoration, disinfect the restoration, send it back to the dental office, and the doctor inserts the restoration into the patient's mouth. So pretty much this is the workflow for a case. So the impressions that the doctor takes, those are negative representations, but then the models that we do, so the impression comes to the lab, we disinfect the impressions and all the materials that comes from the dental office, and then we pour them up in the stone that we need to. So for instance, for the master cast, we're going to use die stone, and also for the opposing, we can use die stone or lap stone depending on what we need to do. So the cast actually represent an exact replica of what the patient has in their mouth, their teeth, their gums. So we can see all the features of the patients in the model that we fabricate. So there are a variety of or different types of impression that the dentist has available to them to use them, and each type of impression require a different type of impression material that has different properties, which are different depending on what type of restoration we do. For instance, in complete denture material, it's needed that it's very accurate, and especially when we're talking about dentures, we have to have that accuracy of the sulcus or the borders, because those are the area that give the denture stability and retention. So the same idea goes for the partial dentures, where there are additional requirements in terms of getting accurate impressions of the abutment teeth and also the gum and the the bone structure. The material must be capable of registering both tooth and soft tissue and, of course, the undercut. In many dental impression procedures, two materials, sometimes or even three, are used in sequence to take advantage of the most favorable qualities of each. So when we're talking about impression material, if you remember from introduction to non-metallic dental materials, when we talk about impression materials, we have different type of impression materials, and for the final impression, we have different type of impression materials in the same system, in the same type of um, impression material that has more or less accuracy. So when we take an impression and we want to see the margin, we can use a different type of impression material around the margin to capture the margin. But for the rest of the patient's teeth that are healthy, we don't need to be super accurate. So we can use a different type of material that gives us the accuracy of the patient's natural dentition, but we don't have a margin and we don't have something that has to be super, super accurate. Early impression materials in the 18th and 19th century, beeswax was used. Like, can you imagine with the wax? The problem with the wax, it's a very soft material and it disturbs faster, especially when it's introduced in the patient's mouth because of the warmth and the saliva, right? And it's very unstable and lack detail. Also, it's very easy to be moved around when the doctor tells the patient bites down on the impression material so he can get a good, accurate impression of the teeth. If the impression material it's wax, it distorts very easily, therefore it doesn't register that detail that we need. 1844 till 1920, plaster and compound were used. There was no elasticity, and the materials were brittle and very easy to break, and not so easy to put them together. So there were dentists in different countries. There were dentists that they like to use the plaster as an impression material. The problem with the plaster is that if, let's say, the patient has loose teeth, maybe has period disease, or they have a bridge that it's not very well stable in the patient's mouth, when they put the plaster in and they take it out, the loose teeth or the bridge that it's not so stable may come out with the impression. So the doctor creates more problems for the treatment of that patient. So it's not something that we want. I don't think today the plaster is used as an impression material, which is a good thing. In 1925, agar hydrocolloid was used for partial dentures. The only problem with the agar hydrocolloid means it's a material that likes water, likes to be wet. For instance, the alginate material, this is the mostly used material for taking preliminary impressions. It's a very good material for taking the opposing impression, the opposing arch impression, or for preliminary work. But once it gets dry, it's distorting very fast and it's not accurate anymore. So the alginate impression must be poured very fast. Once it arrives to the dental lab, it has to be disinfected and poured right away. In 1930, zinc oxide and eugenol paste start being used for full dentures, and they're more accurate, and they kind of last a little longer. So the setting time, it's a little bit longer, allowing the dentist to take a more accurate impression. 1940, the alginate, like we talk about, the alginate material came out, and again, because it's a material that likes water. Once the water evaporates from that material, it shrinks and is not accurate no more. 1950, mercaptan rubbers or polysulfide rubbers were developed, and those are the materials that are more accurate, and also the setting time, it's pretty short, so the patient doesn't have to keep that material for a longer period in their mouth. 1960 silicone rubber, elastic and strong and stable, so it's more accurate. And like I said, those impression materials, they come in different type of accuracy. So you have the light body, you have the hard body. So this combination of materials from the same system, it gives us a more accurate impression material. So we talk about what impression. It's a negative reproduction of the oral tissue model or cast, and it's created by filling the impression with stone or plaster. A die, it's a model of a single tooth, a stone, copper, or silver, or epoxy. Those are the materials that can be used to fabricate a die. Impression materials are used to register or reproduce the form of the teeth and the gums. And based on the impression of taking the, based on the method of taking the impressions, they're either analog, using physical components, or the traditional way where we have impression tray and impression material put in the tray, and the doctor takes the impression in the patient's mouth. Or we have the digital or the CAD/CAM system where the doctor register the the patient's natural and the preparation using intraoral scanner. So we have different type of impression materials. We just talk about this: the plaster, the modeling compound, zinc oxide, eugenol, impression paste, agar, alginate, synthetic rubbers, and silicones. Impression trays are used to hold the impression material, and they are inserted in the patient's mouth along with the impression material to take the mold. Okay. They're different type. They can be disposable, prefabricated, or they can be made in the lab. So this is something that we can do in the laboratory. It's a process that it's done, a routine procedure, especially for more complex cases when we're talking about dentures or partial dentures, implant cases. So this is the type of impressions, custom impressions using custom trays. They come in different standard sizes, so it's small, medium, and large. They can be made of metal, plastic, can be solid or perforated, and for different coverage, either for a full mouth or quadrant. A quadrant meaning 1/4 of the mouth, okay? So for instance, if a patient has just like a small filling, it's not necessary to take a full mouth impression, a full arch impression. We can use a quadrant impression to take the mold just of the area where the little filling, the little preparation, it's done. Okay. Water-cooled bases trays are used also for the agar impression. Agar is a solid gel when it's cooled, heated, and can change to a liquid state, and maintaining the heating pad at a temperature acceptable for taking an impression in the patient's mouth. So if you remember from the non-metallic dental materials, the difference between agar and the alginate impression material. Agar, it can be reusable because you can heat it up and reuse it. The alginate material is a non-reversible material. So this material, once you use it once, that's it. You throw it out and if you need to take an impression, you use new material. So in terms of the stone that we use for fabrication of the dental materials or the models, we can use dye stone, which it's very hard, but it can be brittle. It's not very expensive, but it's the most expensive from all the stones. You have to maintain a correct ratio of water powder as described in the manufacturer instructions. So each manufacturer have their own recipe, how they do the powder mixture for the dye stone, and they recommended how much distilled water you should use for that stone. So follow the manufacturer instruction is the best advice. We can use mechanical mixer to follow the manufacturer instructions. So if you remember, in the labs, we have the vacuum mixer. So especially for the dye stone, it's important to use the vacuum mixer. And again, look at the manufacturer instructions because that tells you how long you should keep that in the vacuum mixer and also the pressure. Okay, so why is that important? Because using the vacuum mixer, not only that it makes the mixture of the stone more homogeneous, but also eliminates any bubbles that might be or air trapped inside the mixture. So when we put it up, we get a nice model without any holes or voids into the impression, okay? And it's stronger. Other dye stones, there are different dye stones based on what type of method of fabrication we're using. So for instance, if we're gonna use a CAD/CAM system to scan our model, maybe we want to use scanning dye stone, which has it's a little more opaque, so the scanner can read better the details of the model, okay? And also there is another dye stone that has resin mixed with it, and it's a little bit stronger, but also when we grind that stone, it doesn't make so much dust like the regular dye stone. Epoxy, it's another dye material that it's very strong, accurate, and best all-around choice. Can be expensive and can be distorted by heat. And in addition, a centrifuge equipment it's needed. I don't know how many labs they're using epoxy this time around to fabricate those dyes, but it's good to know that it's a very accurate material. Copper-plated dyes are very strong and accurate, but it's time-consuming. It's a time-consuming procedure, and it needs special equipment. Digital cast or visual models. So, like I said before, instead of taking an impression, the doctor uses an intraoral scanner to scan the patient's mouth and tissue, and that file it's saved in the computer along with the bite, and that can be sent straight to the lab through the CAD/CAM system, and the lab can start fabricating the restoration using the computer, the software to design and to manufacture whatever the restoration might be. There are advantages with this. The patients likes it because it's faster, first of all, it's more accurate. One thing that it's a big advantage in using intraoral scanner is that we can see the shade of the patient's natural dentition very well. So in the past, when the dentist takes an impression, a physical impression, we rely on what he observed or he or she observed in terms of the shade of the patient. So the doctor might see that the patient has a A1 shade, but it might be one with a more chroma or more value, which it is a A1, but there are certain subtleties that maybe he's not able to transfer to us. So the shade might be a little bit off. By having the digital impression taking through the intraoral scanner, this is a kind of like a photography, like a video that you see of the patient's oral cavity. So we see the color of the teeth, we see the color of the gingiva, so we can determine if what the doctor asks us is correct, or if there are any characteristics that we have to copy in our restoration that the patient has in their natural dentition. There are different type of model materials. So we use gypsum, which is calcium sulfate dehydrate, plaster of Paris or refined near Paris, um, dental plaster, dental stone. Dental stone, it's one of the most used materials, stones in the lab, because we use it for everything. We use it for flasking the dentures. We're using for pre-op models. We use it for ortho models. We can use this material for a lot of purposes. So it's very used in the lab. And again, every time you mix, you're ready to use some type of stone, make sure you read and understand the manufacturer instructions, how to mix the stone, the ratio, the timing, the spatulation timing, all that. It's very important to get the best accuracy, okay? In terms of the strength, so improved stone is the strongest. So when we're talking about improved stone, it can be dye stone that, like I said before, it has some resin in it and it makes it a little bit stronger. Dental stone, it's stronger. And then the weakest, it's dental plaster. Improved stone also can be the regular dye stone. So this is how the electroplated dyes or the copper-plated or silver-plated dyes take place. Usually electroplating impressions, they're using silver or copper plate on the surface of the impression for dyes, inlays, crowns, or bridge restoration. And it uses current 110 volts. It's converted to a low voltage direct uh, electricity current, okay? And this is submerged in the electrolyte solution. And the copper anode, it's inserted, or the copper or the silver anode, it's inserted to one side of the uh, copper plated, and then the cathode also, it's inserted the cathode rod. So the current that runs from the negative anode to the positive cathode carries either the silver or the copper particles that they get deposited on the impression surface, okay? Like I said, this is not something that it's done routinely in the lab today, but it's something that it used to be done, and it's something to know because this is a very accurate type of replicating dye. We talk about the impression, the digital impression system. So the picture on the left, the first picture on the left, you can see the wand. Sometimes it's called the wand, but that's the intraoral scanner. And the pictures that the intraoral scanner takes thousands of pictures in one movement of the assistant or the doctor moving that wand in the patient's mouth, and then the software in the computer combines those pictures to make one big picture of the patient's mouth. So that's the file for the patient. And we can see in the second picture in the middle that actually we use the same um, digital impression to fabricate, to design, and to fabricate the final restoration. Also, if necessary, it's not always the case, but if necessary, we can use those digital impression to to do the model work. And for that, we have to do a 3D printed model. So we can design in the software uh, the model, and also we can articulate the model in the software. So once we finish the restoration, mill it or whatever the case might be, we have a model where we can try our final restoration to see if we need to adjust the contacts, mesial, distal, or occlusal contacts, also the margins, if the margins are good. So it's always good to have printed models to see how the final restoration fits after it's done. So a working cast, it's a cast used to duplicate the patient prepared tooth or teeth. The other teeth present in the arch, so the natural dentition, and all associated soft tissue structures, so the gums. It is used to establish the shape, proximal contacts, occlusal, and fit of the fixed prosthesis, from the simplest inlay to the most complicated, complex mouth rehabilitation. A die, like we said, a die, it's a positive representation of the prepared tooth in a hard, stable material such as dye stone or improved stone, dental amalgam, acrylic resin, epoxy resin, or copper plated or silver plated dyes. Dyes are composed of two parts. The duplicate of the prepared tooth, so it's the part where uh, we mostly work on. That's where we have to uh, design and fabricate the final restoration, and the extension. Usually the extension, to give you an analogy, is kind of like the root of the tooth. So think about it. The root of the tooth stays into the bone, right? And our die has that portion that goes inside the model. So that's the extension to keep the die in position and in the same location how it is in the patient's mouth. By itself, a die has a limited value until its relationship to adjacent teeth and the opposing teeth is established. So what that means, if we do a restoration, let's say we get a die, right? We don't have the model, we don't have the opposing, just we have a die, and we just start doing a wax up. Let's say it's a molar, and we start doing a molar wax up, and it looks beautiful. We put all the anatomy in there, the primary grooves, the secondary groove, everything. It's top notch. Okay, and now how do you know how that wax up relates with what the patient has in their mouth, since we don't have anything else? It doesn't, right? So without having the adjacent teeth, the opposing teeth, we really can't do anything um, in terms of constructing or manufacturing a functional and aesthetic restoration. Why? Because we need to have proximal contacts, we need to have the occlusal contacts. Also, we need to see the shape of the teeth, right, that we copy. And also, sometimes, we get carried away doing the anatomy of a tooth. Sometimes we put too much anatomy, and we don't see the patient. As dental technicians, we don't see the patient. As the doctor, we see the patient. So we imagine that the patient maybe is a young person who has a lot of anatomy, pointy teeth, pointy cusp, but that might not be the case. Maybe the patient is somebody in their 50s where the teeth are worn out, is not so much anatomy in there. So that tooth that we do is not going to fit. It's not going to function properly if we don't follow what the patient has in the mouth. Okay, so that's very important. Working cast contains one or more dies. What that's supposed to mean? Well, depending on how many teeth the doctor preps. So it could be a small filling, it could be two or three um, crowns that the patient needs. So it's a full prep on few teeth. Okay. So we have to know that an impression may contain multiple dies. Dies are either part of a working cast or they're not. For those dies that are not, the extension is a convenient grip and nothing more. So like I said, it's very important for us to look at the dies in context of what the patient has, the existing natural dentation, the adjacent teeth, the relationship between the arches, right? So all this has to be taken in consideration when we design the restoration. So what you see in this picture, you see where the die is with the prep, and the extension, that's the part that goes into the models. And you see where it says the key, that's a feature that we can add to the die to lock the die into the model so it doesn't rotate when we work on it. Ditching is very important, and we're going to talk about ditching later on. But ditching is something that exposes, it's a procedure that we do to expose the margin. So we see the margin and we work to finish the restoration where that margin is. Pindex. So once we pour up the impression and we let it sit and we separate from the impression from the model, now we trim up the models, we make it nice and flat, we trim the excess stone, and we're ready for the next step, which is pindexing. Okay, so pindexing meaning to draw holes underneath the model on the other side of the model opposing to the teeth, so we can put the pins. All right, so that makes the dies removable. So we're gonna make sections of the model that are removable. The dies, they have to be removable. Also some of the sections that are not working areas, so the areas, maybe the adjacent teeth, we can make those removable, but those are non-working areas because they don't contain a preparation. Okay, so for Pindex, we can use either one pin that can have a double pin, or we can use dual. Okay. Drill bits must be purchased from the company that developed the Pindex machines, because each company developed their own drill bits based on the requirements for their drills. Okay, so drilling the holes, what's important when we drill the holes for the Pindex is to drill the holes parallel to each other and kind of keep them in line. So don't drill one hole more the lingual, one drill more towards the buccal. They kind of have to be parallel with each other. Why that's important? Because of the path of insertion. When we're going to take this model out from the base, if each pin is in a different position, what's going to happen? We either going to break the model or we're going to break the base. So we have to start all over again. Okay, so the way we drill the pins and we insert the pins into the models, they have to be parallel to each other, and the holes, they have to be drilled in the thickest part of the model. Okay, in the center, the thickest part of the model. Okay. The dialogue system, there are different type of kind of index and impression and articulation. Those are kind of like disposable articulators. Those are very good, that can be used for single type of restorations, something that is not very complicated. Um, and they have their own Pindex, their own pins. So you don't need a Pindex machine. You just need to insert the pins into the impression when you put it up, and then once you put it up, you can trim it a little bit and then put it into your articulator. So it's kind of like a very nice and easy system to work with, but again, it's a disposable articulator. It doesn't have all the functions of a semi-adjustable articulator, so this is recommended mostly for simple cases. Um, Freehand, it's an old method using inserting into the impression bobby pins and dowel pins with sticky wax to hold them in place, and then the stone is poured over the pins into the impression. Can be used for single unit or very simple cases again. It's not very accurate. Why? Because when we insert the pins into the impression with the sticky wax, keep them in place, sticky wax gets a little bit distort, right? Because when we pour up the stone, what's going to happen? The stone gets hot, and then the sticky wax starts to be softened. So that might move the pin into the impression. So therefore, the impression might not be accurate. So we have to be very careful when we do this type of procedure. Articulation. So an articulator is a mechanical instrument that represents the temporomandibular joint and jaws to which the maxillary and mandibular cast may be attached to simulate all or some of the mandibular movements. So for every case that we work on, doesn't matter if it's a small inlay or we do a full mouth rehabilitation, we kind of use any type of articulation. So we can use, like I said, the disposable little articulation, or we can use the fully adjustable articulation. Even in the cases when we're going to use the CAD/CAM system, every CAD/CAM software comes with an articulation. And also you can ask, for instance, if you're using in the lab, let's say a Jensen articulator, and a doctor that you have in your as on your account is using the same Jensen type of articulation, and you correlate with that doctor how you use those articulator, um, then you can ask Jason company to give you the library, the digital library for the JSON's articulator to insert it in your software. So every time you mount your case into your digital work, your CAD/CAM, you can use that type of articulator to mount the case. So you know it's going to be accurate. It's going to be the same like what the doctor is using in his practice, okay? So articulator simulates the position and movements of the patient's lower jaw in relation to the upper jaw. So prosthesis with a proper occlusion can be made. So think about it this way. Like I said before, we can do a beautiful crown for a patient, right? And we put a lot of anatomy. We made the shade. It's perfect. It's matching the natural shade of the patient. But what happens if we don't use the articulator to do all the movements, right? So when we use the disposable articulator, usually we're using the up and down movement, right? So like the patient bites up and down. And this is fine, but also think about it, when we chew food or when we speak, right? Our jaw moves not only up and down, also there is a lateral movement, right? So those, simple articulators, though they don't have that um, feature for the lateral movement. So let's say we did a crown on a disposable articulator. It looks perfect. It looks like it's fine to us in terms of the occlusal contact. We send it to the doctor. The doctor tries it in the patient's mouth, and he calls us and he said, you know what, that crown, it's so, I can articulating the patient's mouth because the patient can close their mouth. So because we didn't do that lateral movement, the cusp that we did, probably if it's a molar, the cusp that we did are longer, okay? So the doctor sends that crown to us. We have to remount the case, put it on a semi-adjustable articulator, do all the movements, the lateral movements, adjust the crown, send it back to the doctor, and then insert it in the patient's mouth. So this is time and money lost, not only for the doctor, but also for us. So keep that in mind. The accuracy of the simulation depends on the accuracy of the dentist's transfer record and the degree of adjustability of the instrument. So this is very true. So it's based, we can do the mounting accurately, exactly how the patient bites, and record all the movements of the patient's jaw based on what the doctor gives us. So if the doctor gives us an impression that is not accurate, then when we do the restoration and the restoration doesn't work properly, then it's not our fault because the impression was faulty from the beginning. So we have to be aware. That's why, it's good to learn how to, you know, troubleshoot when you have an impression that is not accurate, so you don't continue fabricating the final restoration, send it to the doctor, and then he's going to send it back to you to redo it, okay? There are different types of articulators. So we have the self articulation. It's an old system used with stone only. It's difficult to fabricate, time consuming, not accurate, no excursive moments possible. Excursive mean the lateral movements, or the back and forth, the protrusive and the forward movements, okay? Non-adjustable or straight line articulator is most widely used, inexpensive. Okay, so those are the simplest one that they kind of go up and down. There are no adjustment possible other than vertical dimension and the occlusal centric occlusal relationship. So they're very limited in the movement. Semi-adjustable articulations, they're highly accurate, transfer data from the patient to articulator. We can use a facebow. The facebow is the doctor takes the facebow transfer and he sends it to us with the case. So we can use that one to mount the case accurately. And that's why the facebow is important, especially for complicated cases, because it registers not only the movements of the patient's movements of the jaw, but also the relationship of the condyle when the patient opens their mouth or goes into excursion. All right, so that's very important. Fully adjustable articulations, they're the highest accuracy. Transfer data from the patient to articulator with again with the facebow transfer or Gothic arch tracer, panthenographic tracing. So this is a more accurate records that doctor does for the patient movement and also the oral structure. So the bone, how the the fossa, the condyle moves, the gliding movement of the fossa, everything can be registered in those articulators. So therefore, when we do the final restoration, not only it's going to look good, but also the function is going to be very accurate. So transfer records. Transfer records means to establish a bite registration. Okay, so how the upper arch is related to the lower arch, how the patient bites down. Okay, so the accuracy of the restoration depends on accuracy of the dentist transfer record, also known as a bite registration. So when the dentist takes a bite registration, it's important to know what type of material he or she uses for the bite registration. They might use wax, like, the base plate wax. Again, wax, it's distorting, right? In the patient's mouth, because the mouth is warm, it can be distorted, okay? Also during the packaging, it can be distorted when the case is sent to us. So there are different silicone type of bite registration materials that are very accurate and very stable. So these are the materials that the doctor usually use and send to us with the case. And the degree of the adjustability of the instrument. So this is what we're looking in the transfer record. So is it easy for us to copy exactly what the patient has and put it in the articulator, right? We have to be aware of the vertical and horizontal orientation of the upper jaw to both temporomandibular joints. So in other words, how the upper jaw is related to the lower jaw in when the patient bites down. Patient actual centric occlusion, or the dentist estimation where the occlusion might be. So sometimes we have cases where the patients are in crossbite. Crossbite meaning that the lower posterior teeth are outside of the bite surfaces of the upper, okay? So we have to know that the patient is in crossbite. If we don't know that, if we don't have a bite registration that presents that feature of the patient, how are we going to mount the case correctly? The angles that the articulator emanates from each form with the occlusal plane. So again, this is we're talking about the condyle and also the degree. Some patients, we usually for the semi-adjustable articulation, we use the average measurements of the condyle and the incline plane and all that fun stuff. But in cases that are more complicated, we really want to be accurate. What happens if the patient has temporomandibular joint problem, okay? Then we have to be aware of that, and we can use an average to design and fabricate the case for that patient. So we have to be very accurate, and those transfer record has to be accurate for us to transfer them into the articulator, okay? And the relative presence or absence of anterior guidance. So anterior guidance is given by the, again, how the name says, the anterior teeth. So when the patient brings forward the lower jaw, right, how the relationship between the upper and the lower teeth are taking place. Are they gliding one another, or they have a stop, or what's the relationship there, okay? So we can hand articulator, sometimes for, let's say, we just have to do a wax up, a diagnostic wax up for a patient. For that case, maybe we don't need just to do something fast. We don't need to mount it on a articulator. We can just hand articulate it and just do the wax up, put it with the opposing, and then present it to the patient or to the dentist. Non-adjustable straight line articulators. So those are the articulators that the hinge articulator that just go up and down. So they're not, like I said, very accurate, but they can be used for simple cases. And we have, you can see here in the picture, we have different types. We have the disposable ones, the plastic ones, and also the metal ones, which we can use plaster to help the articulation. The semi-adjustable articulator has enough adjustable features to give fair, good simulation of the patient mandibular movement, because this is the most important thing. We're trying to mimic what the patient does with their mouth, right? When they speak, when they chew, how they move their mouth. Some people, when they open their mouth, they don't open straight up and down. There is a little bit of lateral deviation. So when they open up the jaw might move a little bit to the left or to the right. It slightly could be just 1 millimeter, something very, very small. But if we don't take that into account when we do the final restoration, it's not going to fit well. Okay. So many articulators in this class can be compensated for the angle of a person's articular eminence, horizontal and vertical overlap conditions, and amount of progressive mandibular translation or side shift, the lateral movement. Some have fewer adjustments, no variable progressive side shift, and some have more adjustments, immediate side shift, progressive side shift, and variable intercondylar distance. So every time you purchase a new articulator system, before you purchase it, make sure you kind of look and find out the features of the articulator and how you can use those features for your advantage. If it's something that you're not going to use very often, maybe you don't want to invest money in a system that it's like the Rolls Royce of the industry. Maybe you want something that is like the Cadillac that's going to work fine with you. Okay, so be aware what you need first. Okay, arbitrary or average method. So we talk a little bit about that. It's a statistical averages that are used to set all the remaining articulator adjustments. The so-called average settings are supposed to hold true for the majority of the patient population. When a semi-adjustable articulator is used in this way, it becomes a fixed guide instrument and has the same limitations. So in other words, if we can use those averages for, like I said, more common cases that don't require a very accurate, I shouldn't say, because all cases they should be accurate, definitely. But if the patient require a high degree of accuracy in the movement of the jaw, then we want to make sure that we don't use the average method, and we ask the dentist to take a Facebook that it's the most accurate device to record and register a patient's measurements. Okay. The semi-adjustable method, the dentist articulates the patient cast and sets the articulator adjustments based on the actual patient's measurements. Two kinds of measurement systems are used: Facebook transfer and maxillomandibular relationship record. So both we talk about the Facebook and also the the bite registration. So continuing with different type of articulators, the fully adjustable. So like I said, those are the most accurate articulators, and they register different type of movement and also different type of settings. It takes a little bit of time to learn how to use it correctly, and also again, it's important to have not only for you to know how to use it, but to have that Facebook from the dentist, it's accurate. Okay, so that's what we're going to use for mounting the case. The information needed to accomplish those highly refined adjustments does not come from the maxillomandibular relationship records or from the bite registration. It comes from the mandibular movement tracing or recording by the patient under the direction of the dentist. So the dentist tells the patients to move the lower jaw in different direction, up and down, back and forth, side to side. Okay. Fully adjustable articulator are used on the most demanding kinds of cases, that is, detecting and treating patients whose jaw's movement patterns are not normal and completely full fixed prosthodontic restoration. A fully adjustable instrument can be used in the fixed guide and semi-adjustable modes if a less adjustable articulator is not available. So in other words, if you have a fully adjustable articulator, but for if you have a case that it's average, you can use it with the average method, then you don't have to use all the bells and whistles of the articulator. You can use it as a semi-adjustable articulator. Archon versus non-Archon articulators. And this is something that you have to keep in mind and you have to learn, because this is very, very important. Not only that it's used in, the traditional method, the physical method of fabricating or restoration, but also in the digital, the CAD/CAM system. So the Archon articulators are the articulators that the lower part of the articulator it's moving, and it's kind of exactly how it's more accurate, because that's exactly how we have our jaw, right? When we talk, when we eat, the upper jaw doesn't move, it's the lower jaw that moves, right? So the Archon articulator are the more correct articulator, because the more accurate, because the lower part of the articulator mimics exactly our lower jaw, how we move it. The non-Archon articulators are the articulators that they use the upper part of the articulator to mimic the movement, which is not correct. But the way the articulators, those non-Archon articulators are set up, they can be used also for these purposes. But if you want to do more accurate work, when we're talking about complete dentures, when we're talking about partials, implant cases, full mouth rehabilitation, we want to use Archon articulator. Okay. Facebow. So the facebow, it's a caliper-like instrument that relates to an upper cast to the condyle. Okay. Elements, and it's the same way and registered the same way the patient's upper jaw relates to the temporomandibular joints. Okay, so you see here an example of the facebow. So how the doctor inserts the facebow into the patient's mouth and records the movements and the bite, and then when he sent the case to us, the impressions to us, also he sent us the facebow. Now each articulator system, they have their own facebow. And remember how I said earlier that sometimes you may use a Jensen articulator and the doctor may have a Jensen articulator. Why? Because the doctor can take a facebow using that Johnson articulator and send it to you so you can mount it on the same articulator. Okay, so each system, articulating system, they have their own facebow. They're not interchangeable. Okay, so make sure when you receive a facebow from a dentist, you understand what system they're using, what articulator system they're using, so you mount the case on the same articulator. Okay, so the facebow, it's attached to the articulator, and then the upper cast, it's placed into the facebow where the records, the teeth records are, and then it's mounted to the articulator with the plaster. Once it's set, then the facebow, it's taken out from the articulator, and then the lower jaw, the lower cast, it's mounted to the upper cast. Okay, so that's pretty much how the mounting take place. Average setting of the horizontal condylar guidance. So the steeper the angle of the eminentia, the steeper the cusp might be. Okay, so if we look at the picture here, we can see that the average is about candelar inclination. It's set at 30-degree angle. This is the average. Okay. The shallower the angle the eminence of the eminentia, the shallower the cusp might be. So some, and you're gonna learn this in dentures probably when you set up and you choose your denture teeth. You can choose teeth that they have, let's say, 0 anatomy, 20-degree anatomy, or 33-degree anatomy. So the 0 anatomy, that means the teeth are almost flat. There is no too much grooves inside, and the cusp are very minimum. 20-degree, the cusp are present, but again, the occlusal anatomy, it's almost flat. 33-degree teeth, they're anatomical, so you have all the features that you see in, let's say, younger person, where, they have pointed cusp and all the anatomy in there, the primary and secondary groups, all that fun stuff. So the what the slide is telling you, that the condylar inclination, the average, is based on the um, the cusp. Okay, so the shallower the cusp, the shallower the angle. Okay. And also, this is a little presentation of the Stratus 300 articulator. So these are the ones I think that you're using in the classroom, in the lab. Um, it's a very good semi-adjustable articulator. It's very easy to work with. The thing that you have to be aware of is the mounting plates. So each articulator system, they come with their own mounting plates. There are some universal mounting plates, but you have to make sure that they kind of fit with your articulator. Some of them, they said they're universal. You buy them and you try to put it on your articulator and they don't fit. So my recommendation is always buy the mounting plates that goes with your articulation that you're using. Also, the Stratus articulator, what the feature that I like the most is the little pin that you see going across, and that helps you to guide where to place your anterior teeth. Okay, so it's very useful. And also a little more about the Stratus articulator. And also you can see that actually the Stratus articulator comes with their own face bow. Okay, so I think so this is what entails to fabricate a cast and a model. And we're looking for accuracy of the impression based on the dentist's ability to take an accurate impression and using the right accurate dental material. Once the case comes to us, we have to disinfect it, pour up the impression using the stone that it's recommended for that type of procedure that we're doing, and also read and understand how the stone should be mixed using the instructions from the manufacturer. And once we have the models done, then we can proceed to Pindex, insert the pins, make sure that the pins are parallel to each other, and also they are in the thickest part of the model. And then we're ready for articulation. Okay. All right. So if you have any questions, please bring them on. Thank you.